صباح الخير. عنا هون وعنكم انتم هلا بعد الظهر. الف شكر دكتوره لبنى، والدكتور نزار، دكتور جورج، دكتور مازن. وانا اسف انه بعت هالريكوردينج شوي ليت. انا ظنيت انه بدي احكي مع الزوم مباشره. راح احكي بالانجليزي اذا كان ما عندكم مانع، لانه هي اسهل الي وبتامل يكون مفهوم للحاضرين. انا بعرف انه الحاضرين ما كلياتهم هن respiratory physician. I'd like to talk about the molecular biology in asthma management, and I would like to talk about only four areas, and these are the areas I will be addressing. For most people who work in respiratory medicine, they have noticed that there are different responses to the inhalers that we give them in terms of asthma management. This is particularly important study has been published in 1999 from the US about the effect of Bicotide or biclomethazone, which is a very known inhalers. And this is the percentage of patients who have improvement. And the majority of patients will have some sort of improvement to biclomethazone, but the other majority do not improve at all. Some even deteriorate. And this variation in response to biclomethazone has prompted the question whether there is any genetic basis to respond to biclomethazone. And this is in fact from Harvard, from Boston, looking into the genetic of people in way of responding to inhaled steroids and to the other inhaler, long-acting bronchodilators. And these are their genes. And if you look to the genes carrying arginine, and the genes which have glycine, the response to inhalers are very different. This is the level of peak flow to the first group of genes, arginine, in which there is no improvement at all, or almost no improvement at all on the inhalers. Whereas if you look to the glycine, they improve on fluticasone alone, which is the inhaled steroid, and better still on the fluticasone and salmeterol, which is an inhaled steroid and long-acting bronchodilators. So the response to inhalers are different between genetic profile. This is another study from similar group, which is showing the degree of exacerbations. Look here, the peak flow, but this is the degree of exacerbations of people who carry the glycine, and this is the dose of steroid they are taking. And the higher the dose, the lower the exacerbation rate annually for the glycine group. However, the group which has arginine in them, there is no effect on the exacerbation, no matter what the steroid dose increase. So the first conclusion is that genetic profile does affect the response to inhaled steroids and oral steroids. Remarkably, those who have the arginine, the non-responders, were the Black and Afro-Caribbean population compared to the whiter population. In Syria, there is these modalities are not available, but it just highlights that there is genetic profile to things. However, what is available in Syria is the eosinophil in the blood, and the role of eosinophil has become to prominence fairly recently. In fact, this is a study just to show the predominance or the prevalence of high steroid in your blood and my blood. This is a study of 3 million people in which they found that the eosinophil count in the plasma of over 300 mils was available in a third of the population with COPD without asthma history. We don't know what eosinophils do. Eosinophils come from the bone marrow, get in the circulation, and probably their role is to increase when people are exposed to material the individual are allergic to, such as a flower, house dust mite, or in fact to be anti-parasites in the body. I think this is the immunological role of eosinophils. When eosinophils go into the bronchi, there is an eosinophil inflammation, and that can be detected by increased exhaled nitric oxide, or what we call fractionated exhaled nitric oxide. And this is a simple machine that detects them. So this large study has shown high prevalence of eosinophils in the blood in people without asthma history, and found that the eosinophil in the bronchi, as detected with fractionated exhaled nitric oxide, was 1 in 6 population. So high eosinophil count is fairly common. This is another study showing that the majority of the population would have what we call normal eosinophil count, but some will have high eosinophil count and some will have low eosinophil count. This is from England. This is one of my patients, and this is the analysis of eosinophil in their body between April 2011 and July 2016, so over a 6-year period. And you can see that there are plenty of occasions in which their eosinophil count are pretty high. This is the upper limit of eosinophil. So it's a pretty common, and we think that higher eosinophil count are associated with more exacerbations in COPD and in asthma, and higher eosinophil count, on the other hand, will show that they do respond to either oral steroid or inhaled steroid. Because of that, there have been now many biological components, which can combat high eosinophil count and can affect the natural history of asthma. I will go now into 3 biological factors, then I will make a comment about the role of biological factors in general. The first biological factor is this material called mepolizumab, and mepolizumab is anti-IL-5, and IL-5, interleukin-5, attracts eosinophils to the bronchi. So mepolizumab is anti this material which attracts eosinophil to the bronchi. This is a pivotal study on looking at nearly 600 patients, in which people have been given 2 doses of mepolizumab or placebo in triple blind placebo-controlled study. And this is the asthma exacerbations. And this study has shown both doses of eosinophils of mepolizumab are very effective in reducing exacerbations compared to placebo. Remarkably, those has been included in the study have to be frequent exacerbators, in that they have 2 exacerbations in the year prior to the study, and on inhaled corticosteroids at a larger quantity, and to have high eosinophil count. So mepolizumab is very effective in people who are frequent exacerbators, even if they were on high dose of steroid, but they need to have high eosinophil count. The medication is given once every 4 weeks. So mepolizumab, which is anti-eosinophil, is effective. This is benralizumab, which has really the efficacy of linking or preventing the link between eosinophils and natural killer cells. And for that reason, it has become an anti-eosinophil, anti-asthma medication. And this large study looking into the effect of the annual exacerbation. So this is annual exacerbation rate. Annual exacerbation rate, for example, here, no exacerbation, 2 exacerbation, 3 exacerbation, 4 exacerbation. These people taking placebo. These people are taking benralizumab. This group here have low exhaled nitric oxide, and this group have high exhaled nitric oxide or high eosinophil in the bronchi. And this medication had spectacular effect on exacerbation, reducing them by 80% on any groups, whether it is low or high eosinophil nitric oxide. And this group are the atopics, i.e. they have a history of allergy everywhere else, and this group is non-atopic. So benralizumab is fairly effective medication, and in fact, benralizumab nearly wipe eosinophil count. This is another study in people who have uh, um, polyps, nasal polyps, plenty of them, 205. Those people with asthma without polyp or rhinosinusitis, or people with rhinosinusitis, i.e. Nasal polyp, and again, eosinophil count is very, very effective on all exacerbation and on severe exacerbation. But remember, benralizumab really wiped the eosinophil count, which has by itself some detrimental effect. The other medication is called dupilumab, and dupilumab is blocks interleukin 4 and 13. Incidentally, I thought Dr. Lubna will be presenting the biologics of mediators in asthma. This is why I didn't really talk more about them in addition to the time. But dupilumab is remarkable. This is, again, a large study in the New England Journal of Medicine in which they looked into two doses, 200 milligram and 300 milligram of dupilumab, and two placebos, because the doses come in different sizes. And these are the FEV1, which is the measure of lung function test. And as you can see, dupilumab over a year period does improve FEV1 or lung function test compared to placebo. The injection with dupilumab as well as benralizumab is 2 weeks compared to 1 every 4 weeks in omalizumab. Finally, I would like to talk about the oldest medication, which is omalizumab. And omalizumab, it is anti-IgE, has nothing to do with oxygen, is given subcutaneous every 2 weeks, and people who have raised IgE and have multiple exacerbation needing oral steroid. In England, they don't give it to people who have who smoke. And as you can see, omalizumab does reduce the exacerbation rate modestly compared to placebo, but it does reduce that, and it is consistent. I would like now to caution regarding the expense of biological agents. This study has been requested by the World Health Organization, who realized the flourishing role of biological agents. And this study has been done by Elizabeth Bell. I'd like you just to pay some attention to this study because it has really quite importance in our daily practice. This is 22 poorly controlled asthmatics. Half of them are on oral steroid already, and all of them on high dose of inhaled steroids. All of them given triamcinolone, and triamcinolone is available in Syria. It's long-acting injectable steroid. The reason why they are given that is to ensure compliance. So they will give it to people in the clinic. This is the other given triamcinolone or placebo, and it is a crossover study. The people have been studied before the triamcinolone is given and 2 weeks after that. And they looked at two things. The first is sputum eosinophils, and the second thing is lung function test, and look to the results. For the placebo patient, there have been no change in sputum eosinophil after 2 weeks. In fact, if anything, the sputum eosinophil has increased. But for the triamcinolone group, they have wiped eosinophils. This group, as I mentioned, some of them are already on oral steroid. They say they are on oral steroid, and they say that they are taking their inhalers. But when you give them injectable steroid, it wipes their eosinophils. When we look to their lung function test, it didn't change with placebo, and it did improve with triamcinolone. That indicates that there is a large proportion of people who say that they are taking oral steroid, And those who say that they're taking inhaled steroid, actually they do not. And when they are given triamcinolone, this has shown with the eosinophils and with improved lung function test. And the World Health Organization have mentioned that people have to take their medications before they are offered biological agents. Those people, the 22, would normally are given all of them biological agent by the current standard. And the World Health Organization saying, make sure that they are taking their medications before offering them biological agents. Finally, this is an important message, especially to our colleagues in Syria. This is a case study from the American Thoracic Society meeting in a couple of years' time about a 54-year-old patient who had eosinophilic asthma and who was on benralizumab. He had no eosinophil counts in his blood at all. He presented with progressive breathlessness and one episode of hemoptysis. None of this responded to nebulized bronchodilators or prednisolone. The CT scan has shown ground glass opacities in both lung fields. The sputum test has shown strongyloides is one of the worms. And in fact, the transbronchial biopsy has shown strongyloides. So when we gave benralizumab, which wiped the blood eosinophils, opportunistic bacteria and opportunistic parasites can grow. In our country, it is possible that is ascaris. So when we give people biological agents, please pay attention also to whether they have any worms in their bowels or not, and probably a screening stool test may be in order. So these are the things that we have looked into, that molecular biology has role in asthma treatment. Pharmacogenetics is promising when it is available and cheap to everyone. Eosinophil counts and IgE available biomarkers in asthma management. And we have looked into omalizumab for IgE-related asthma with frequent exacerbation, mepolizumab for all eosinophilic asthma, benralizumab for all eosinophilic asthma, especially atopics, dupilumab with atopic asthmatics and dermatitis. I didn't mention, but asthma patients respond particularly to dupilumab. A proper assessment for adherence is needed given the high cost of biologics, so make sure that people are taking their original cheap medication. And we need just to pay attention to opportunistic parasite, which can be activated when eosinophil count is very reduced. ألف شكر لكم وبتمنى لكم مؤتمر جيد وبتمنى لكم إنه بقية الجلسة تكون كمان ممتعة ومفيدة. ألف شكر.